to our April conversations on brain health. This is a webinar organized by Rush University Medical Center. My name is Augusto Mirabade. I am a neurologist and I am the chief of the MS division at Rush. And it is my honor to introduce today a colleague and friend of mine, Mike Elson. Mike has been an amazing resource for our patients at Rush very early since I arrived in July. I needed help with a patient with a foot drop. And I started asking around, and everyone said, "You need to talk to Mike." So I'm glad I had a chance to meet him. And very quickly after that, it became clear that we had to have a way, a process, or a system for our patients to have a chance to meet with him and get an assessment and evaluation on a very important topic, which is foot drop. So we thought that inviting Mike today will be a great way for him to educate all of us in foot drop, but also to share some exciting developments that happened in the last decade regarding treatment. So without further ado, Mike, I would like to officially welcome you, and the floor is all yours.
Perfect. Thank you, Dr. Mirabali. Yeah, I mean, this is going to be a conversation, so if there's any questions or anything like that that you guys have, feel free to stop me, ask questions. We'll try and keep this as interactive as possible. So today we're going to talk about foot drop, walking impairment, neuromodulation devices, and orthotics. First of all, a little bit about me. So I'm a CPO, that is a certified prosthetist orthotist. So prosthetist is when I'm designing artificial limbs for amputees, and orthotist is when I'm designing orthotics for patients. I'm from Oak Park, Illinois, a suburb of Chicago. I went to U of I in Champaign. I was an engineer. I was in material science engineering with a focus in biomaterials. I worked out of school at a beverage manufacturing company doing R&D, basically tensile testing on beverage cans, and it wasn't very fun. So I knew of this field, orthotics and prosthetics, because my little brother had braces growing up. So I did a shadowing at one of the offices in Oak Park, and then I liked it. So then I went back to school at Northwest. At Rush as a clinician and a clinic manager for about 10 years, and area clinic manager, so beyond seeing patients and managing my office, I also manage 5 other offices in the Chicago area. And married with 3 kids. In the upper right, that's Maeve, she's 5 now. Lower right, that's Theo, he's 3. And then in the left there is Hugh. So I get to go home and play with 3 little ones. So busy, busy, busy. So again, what's a CPO? Certified prosthetist orthotist. Like I said, people come from all different backgrounds. I was an engineer. My colleague, she was kinesiology. Some people are art majors. They come from all different backgrounds. Some are pre-med. And then you apply to school. Nowadays, it's a master's program. There's about 13 schools across the country, so it's a pretty small field. And then after that, you do an 18 to 24-month residency, and then you sit for your boards, and then you're a certified prosthetist orthotist. So just to show you how small the field is, my certification number in the entire U.S. over the last 100 years is 3,485. So pretty small. Not too many people know we exist, okay? But we do. So whenever I see a patient that has MS, I'm always trying to gear my evaluations towards their goals, right? So what is the main thing for my patients? I'm trying to maintain their independence. Maybe MS has taken away their ability to stand up and walk around their house, or maybe go outside and walk outside. Those are some of the things that I want to talk to the patient about and figure out what they want to be able to do again. What were they able to do before MS has taken away some of their activities of daily living? You know, do I want to maintain their mobility? Maybe it's as simple as they're in a wheelchair 90% of the day, and then they stand up and they have to transfer to a commode or to another chair or to their bed, and they're having falls. So maybe I'm just designing something just for transfers. Maybe they are live in the city of Chicago and they're going to Costco and they start tripping. Maybe I have to design something for that. But basically, my goal is to figure out what the patient wants to be able to do and how can I make something or design something so that they can do it safely. Um, Oftentimes with MS, we'll see patients who have what's called a foot drop. So as your muscles get weaker, your dorsiflexors are muscles that help lift up your foot as you're walking. And if those muscles aren't lifting up your foot as you're walking, there's a chance that you could catch your toe and trip and fall. Oftentimes, like in patients' homes, they know their house, they know how to walk in their house, so they're not going to fall. But it's when you're going outside and there's a crack in the sidewalk and you're going to catch that toe and trip and fall, and now you end up in the hospital with a broken hip or something like that. Or maybe you're going to a friend's house and the carpet is just a little higher than you're at your house, and you catch your toe and you trip and fall, right? So that's kind of my main goal is when I'm evaluating my patients, figuring out what they were able to do before, what they want to be able to do, and how can I design something to help them. Okay. In terms of orthotics, we make something that needs to fit the patient and that they're actually going to use. If they're not going to use it, then there's no point, right? It's just going to go in the closet. So I need to really get a good background from my patients and figure out what they'll actually use and use on a daily basis. Okay. So when we're talking about orthotics, right? What are the different goals for orthotics? Maybe the goal is to create stability. Maybe that patient that stands up and transfers, their knee buckles because they just don't feel safe. And I have to create something that's going to give them some more stability at their knee so that they can put weight through their legs so that they can do a nice transfer and be more independent. Maybe another goal is maybe preventing deformities. Maybe with MS, you're starting to have higher spasticity. And now you're starting to create a plantar flexion deformity, basically where you can't lift your toes up to 90 degrees and your ankle's starting to get tight. So maybe we have to design a brace that's going to hold your foot in a good position to try and prevent that deformity and that reduced range of motion. Because eventually, if you keep getting stuck in a plantar flexion position, it's going to be really hard to stand and ambulate, and it even gets to a point where it's hard to put on shoes. Okay, so maybe that's the goal, just to prevent a deformity. Maybe it's to improve gait efficiencies, like we talked about, foot drop, buckling, things like that. Preventing falls is always a big one. Maybe it's reducing pain. Maybe because of the weakness, you're having severe back pain because you have some sort of compensatory movement so that you can clear your foot, or you're having some knee pain because your muscles aren't working correctly. So that might be another goal of the orthotic. Promote healing. Sometimes we'll see patients that had a fracture and they need something in order to stabilize that joint or wherever the fracture site is. Or maybe we're trying to prevent surgery. So when I'm doing these evaluations, these are the things that I'm thinking about when I'm talking to the patients.
So, Mike, let me ask you a question.
Yeah.
This is great to have the goals kind of outlined because it in a sense, it helps us organize, our thought process of how and when to place a referral. And so, and I can imagine that all of these goals will depend on how advanced that foot drop is. So, based on your experience, how early or late we should be thinking about orthotics in the context of a foot drop?
Yeah, I mean, in terms of early, as soon as you're starting to notice gait deviations, the very first thing that you'll notice with a foot drop is you'll have what's called foot slap. So you use those dorsiflexor muscles as you're taking a step to control your foot coming down to the ground. So you might be walking and you're hearing your foot hit the ground. It's because those muscles are starting to get weak. It's not going to cause a fall yet, but that's something you have to watch out for, because once those muscles start to get weaker, then as you're trying to take a step and clear your foot, that's when you're going to start tripping and falling. So I would say as soon as you're starting to notice that weakness, and maybe you're noticing like, okay, normally I would go to the grocery store and I was fine walking the entire time and came home and I was fine. But now I'm starting to, maybe I have to limit my time at the grocery store. Maybe I can only do half an hour. Maybe I have to go get a scooter because I'm starting to get tired. Once it starts to affect your daily life and stopping the things that you want to be able to do, and an orthosis early on for like a foot drop or something like that is something super easy so that you can continue doing the things you want to do um, as much as normal. On the other end, um, you know, someone who might be completely flaccid and aren't really able to lift their foot up or down at all, those goals might be totally different. It might be literally they have to transfer and their caregiver or their spouse has to try and lift them up to transfer them. And it's a lot of stress on that caregiver or spouse, and it throws out their back or something like that. So it might be a brace that while you're standing, you're able to put some of the weight through your own legs to reduce some of that burden on that caregiver or spouse, the person who's transferring you. It might even be to the point where maybe you're not ambulatory anymore, but you're in a wheelchair, and because of that spasticity, you're starting to get that tight heel cords. So maybe we're trying to prevent a deformity like that. So it all depends on what's going on, and everyone's MS is different.
Very good. Well, thank you, Nate. I'm going to take this opportunity to invite all the attendees to write your questions in the chat box. We want this to be as interactive as possible, so please feel free to write your questions, and we'll make sure to address them during the event.
So I'm not going to go into too much detail here. This is the gait cycle. The big thing is, like I talked about, when you first put your foot on the ground, you might notice what's called a foot slap. And as you're walking across your foot, you might have what's called a buckle, where your knee kind of gives out. And then during swing phase, you're trying to clear your foot. Okay. So when I'm evaluating patients, I'm kind of breaking it down on what's going on in each of those different phases, and I'm trying to design something to enhance those different phases. So there's what's called AFOs, which stands for ankle foot orthosis. Okay, these cross the ankle and can basically control the ankle and then also help influence what's going on at the knee. For my MS population, I really like to do what's called carbon fiber AFOs. So it's kind of the same materials that they make like sports cars out of. I'm a big Formula One fan, so they make the Formula One cars out of it. It's super, super lightweight. It's easy to fit into shoes. So if you have, some small shoes or something like that you want to be able to wear, oftentimes patients are always upset that they can't get their braces into shoes, but carbon fiber AFOs you can fit into most shoes. It's super lightweight. Oftentimes, MS patients might have some weakness proximal at their hip. So anytime I can reduce the weight down by their ankle, it's always advantageous. Another thing, there's not much contact. Sometimes MS patients have heat sensitivities. So if I'm going to design a brace that wraps all the way around and you get super hot in it, you might not like to use it if you have a heat sensitivity with your MS. And also they're dynamic. Because it's carbon fiber, it kind of acts like a big spring. So this here is an example. You can see. This is an example of a carbon fiber brace. It's super lightweight. It's easy to fit into shoes. So basically you take the insert out of your shoe, you slip it in the shoe, and then you slip the insert back on top. It's not really touching your skin anywhere except up here at the calf band. Okay. And then it's like a big spring. Okay. So as you're taking a step, it's going to help lift up that foot so you can clear it, so you can keep walking safely and prevent those falls. So I like to do a lot of carbon fiber AFOs for my MS patients. Here we go. We got a question here. What are the advantages and disadvantages? Oh, I missed that. Katie or Catherine, can you see what the question was?
Sorry, I have too many things open. I'm trying to.
It's okay. It comes on my screen for about a second and then it goes away.
Yeah, it's.
You want me to read it?
I say you got it, Kathy.
Yeah.
Okay.
So the question is, can these AFOs reverse some of that possible deformity, cord tightness, and improve gait if it has been going on for some time before getting the AFO? I will be getting the light carbon type you are describing. What should I expect?
Yeah, it's not necessarily to improve it. That's more of working with the doctors. Maybe you're doing some sort of baclofen or something like that to reduce that spasticity. It all depends on what that tightness is from. Sometimes it's a tightness that has no range of motion to it. Mainly the goal is to prevent that from getting worse. Hold it at the position that it's at, and then you work with your doctor, work with the physical therapist, and trying to improve that range of motion. That makes sense.
Yeah, and just to add to that, I think that's kind of like the timing situation we were discussing before. In general, the earlier we find ways to stabilize the joint, to provide this extra support that the A4 perhaps does, and to prevent, deformities, that allows to retain some degree of symmetry in the gait and ambulation. And then when you do physical therapy, you ultimately get the most benefits out of that. And of course, a good physical therapist is going to know how to work with you, even in the context of asymmetric gait. But the sooner you address these issues with the right AFO, in this case, the better the chances are to prevent further damage, to prevent further worsening, and in some circumstances to improve function.
Exactly, yeah. So with any type of new orthosis or anything, getting into physical therapy is always super important to learn how to use it. It changes the way you walk. So having a physical therapist take a look at you and start working with you is always a good idea. Are there any other questions there?
That's it for right now.
Yeah, and we did get one in the Q&A saying that the chat is disabled, and just to clarify for the participants, the chat between participants is disabled, but you can send questions directly to any of the panelists. So we'll wait and watch for them to come in and stop and answer them periodically. So still working, don't worry.
So those are carbon fibers. This here is another type of carbon fiber AFO. Okay, this is a custom one. So we're actually taking a mold or a scan of the patient, and we're able to provide more control. Maybe that we need to provide a little control of their ankle, or maybe I need to make it stiffer because they have weaker muscles proximally. You can still use the carbon fiber material to keep it light, but I can play with different design characteristics to achieve what I want to do. So these are, sometimes you might see these are the carbon fiber custom AFOs. Okay. Another type of AFO is custom plastic or polymer AFOs. A custom plastic polymer AFO is we take a mold of the patient, and I would use this for patients that I need to control more than one plane. So let's say their foot turns to the side, what we call inversion or eversion. I might have to go with something like this so I can control what's going on at the ankle or what's going on up further at the knee. These are a little heavier than the carbon fibers. They wrap around a little bit more. So I try to avoid these for my MS patients, but sometimes this is the best design for them. Okay. In terms of AFOs, insurance covers them. Typically, Medicare covers them at 80%, and then you have some sort of secondary insurance. Okay. A good orthotist is going to make a brace that fits you really well. You're going to use it. If you have any adjustments, you'll go back to them. If you're not able to use your brace, go back to whoever made it. It's their job to make sure it fits you. Okay. That's probably one of my biggest things. If you're not using it and it's in the closet, reach out to the orthotist. Okay. I saw something. Go back to the chat. How do I get to the chat?
So the question that came through in the chat is,
Yeah.
we discuss hip weakness.
Yeah. So oftentimes you have what's called the dorsiflexion weakness at the ankle, and that prevents you from clearing your foot. But another component of clearing your foot is being able to use your hip flexors. And your combination of your hip flexors and the muscles at your ankle cause your knee to bend when you take a step. So if you have weak hip flexors and you're having a hard time bringing your leg through, okay, sometimes it doesn't matter what type of brace I put down at the ankle, you're still going to have a hard time clearing that foot. So sometimes I'll have a patient come in, we'll try out different braces. We'll try out, functional electrical stimulation, which we'll talk about here in a little bit. And it doesn't matter what I do at the ankle, you're still not going to be able to clear the foot because what's causing the foot drop is what's going on at the hip. The hip is too weak. But if you have a weak hip, I always try and go with some sort of materials that are lighter, so it's less weight for that hip. Any other questions there?
One more just came through saying, if you're hitting the ground on the quote unquote swing, is it foot drop or something else?
Well, we would call it, I mean, if you're catching your toes, we call it foot drop. That's what we call it. It could be a weakness at your ankle, or it could be a weakness more proximally at your hip. Either way, it's a foot drop, and it can cause a fall, which is what we're trying to prevent. So my goal is to create something that's going to make you more stable so you can keep walking and you're not falling. Because we don't want you, as an MS patient, we want you up and about as much as possible. It's good to be active, right? We don't want you, if you're in a wheelchair, we don't want you to be in the wheelchair all the time. If you're able to get up and walk around your house with a walker, maybe just a few steps, that's great. If you're able to stand while you're watching TV, that's great. If you're able to walk outside, that's what we want you to do. The more you just sit and you're not active, it kind of, I don't know if Dr. Miravalli, if you want to comment on that.
Absolutely, Mike, and I cannot agree more. It's not only that, but also I think the purpose of this conversation today is to kind of educate our patients on all the options that are available, and also convey the message that it's never too early to discuss these options. And the reason being, even in the cases of very subtle weakness, if you can address that with the right orthotics, with the right devices, then all the exercise that you do, you're going to get the most out of it. If you think about it for a minute, it takes more effort for the brain to have to correct a weakness than if you really have that addressed by an orthotic, and then your brain can focus on getting the benefits from exercise. So it's never too early to at least have an assessment and see if there is anything else we can do to help you get the most out of the exercise you're doing.
And a question I often get is, the brace going to make me weaker, right? No, not really. When I'm talking to the patients about when to use the brace, I'll say maybe it's not till later in the day when you're tired and you normally wanted to be able to walk, but you're not able to because you're worried you're going to catch your toes and you're looking down at the ground all the time. I'd put it on then. Maybe you don't need to wear it all day long. Maybe it's just for certain instances when you're going to go outside and walk to the park. So it's not something you have to put on in the beginning of the day and wear all day long. you start to learn it's a tool to help you walk better, to prevent falls. So it's not really going to make you weaker. The goal is to allow you to continue to be independent and walking. All right, let's transition into FES. It's functional electrical stimulation. Okay, these are devices that are controlled by the FDA. Typically, these devices are used for patients with MS, stroke, CP, traumatic brain injuries, incomplete spinal cords. So basically, functional electrical stimulation is kind of like almost like a glorified TENS unit, right? It's sending a stim to a muscle to contract that muscle and cause that muscle to contract, right? It's a cool technology because it's your own muscles doing it versus an external brace. Whenever I evaluate a patient for FES, I always talk to them about a conventional carbon fiber or plastic AFO. It's a technology. Technologies don't always work all the time versus a AFO, carbon AFO or whatever is always going to work. So I always do the two in tandem. Okay, maybe there'll be some time when they prefer to use their AFO. Maybe there's sometimes they prefer to use their FES device. Okay. What are the contraindications? So these are the first questions we ask when we do an evaluation. Do you have a pacemaker? Are you pregnant? History of seizures? Do you have a peripheral nerve injury? So basically, it doesn't matter how much we stim, the circuit is no longer working. Or do you have some sort of metal implant, like a knee replacement or something like that? Okay. So if you answer yes to any of those, you're contraindication for FES. So why do we do FES? It's going to help reduce falls. It's doing kind of the same thing as an AFO. It's helping lifting up that foot while you're walking so that you're not going to trip and fall. Or maybe we're doing an FES device where it's stimming the quad muscles. When you feel like you're all of a sudden about to buckle, the device kicks on and your quad muscles contract and prevents you from buckling. Okay. What's very cool about FES is it can help prevent muscle atrophy. Okay, because it's your own muscles doing the work. It's not an external device that sits in the shoe and is attached to your leg. It's your own muscles contracting. Okay, so that can help prevent muscle atrophy. Oftentimes, FES devices even have a mode that's called training mode. So you could actually sit there, watch TV, turn your FES device on, put it into training mode, and it's actually going to go ahead and stim and contract your muscle even while you're just sitting there. Okay. So I often tell patients, the goal, and FES isn't necessarily going to make you stronger. There are some patients that do see some muscle gain with it, but the goal is to really maintain that muscle strength that you have. Okay. FES has been shown to promote neuroplasticity. Basically, we're working the nerves, which sends that information to your brain, which can help with neuroplasticity. It can improve your range of motion. If you have spasticity, when the FES device is stimming your dorsiflexors, the muscles that lift up your foot, your plantar flexors automatically kind of turn off. It's hard for both muscle groups to be on at the same time. So if your dorsiflexors are being stimmed, your plantar flexors, which are the ones that are usually tight and spastic, will kind of turn off. So I've actually had a fair amount of patients that are spastic. They'll put on their FES device for an hour or two, and then their spasticity reduces and they're able to go about their day. So that works for some patients. One of the goals is increasing confidence so that when you're walking, you're not going to fall. You can walk barefoot with an FES device. You don't need a shoe. All type of AFOs, braces, they require shoes. Well, let's say you wanted to go to the beach and walk on the sand. FES device might be your best bet. And then like what I talked about, there's walking versus training mode. So what are the different companies that are out there? So I'm not really, I kind of evaluate patients, and I'm kind of straightforward with patients, and I'll let them know if I think they're a good candidate or not. It's a technology, and it's not always easy to use. So if you get frustrated with technology easily, it might not be the best thing for you. And my goal is to get something for you that you're going to use and you're going to be confident with. What I think is the best one out there is what's called the Bionus. It's the Bionus L300 Go. There is a calf unit, and then you also have the availability to have what's called the thigh unit as well. Back in the day, Bionus had like a heel switch. That's the only way it worked. So you'd have to wear a shoe, and you'd have to have this little switch in your shoe, and that's what told the device to go on and off. Nowadays, there is no heel switch, and there's basically a little computer. Here's one right here. Okay. There's a little computer here, and based on the movement, we program it to go on and off at the right times. Okay. So Bionus is very easy to use. You wrap it around your calf, right below your kneecap. There's a cloth electrode. Back in the day, most electrodes were gel, and they would dry out within like a week or so. These are cloth electrodes that Bionus uses, and it's a bigger surface area. So I used to do a lot of walk aids, and the gels would always dry out, and you always had to have them perfectly in the right spot in order to get a good response. With Bionus, there's a lot more wiggle room, so you don't have to be precise every single time you put it on. So these cloth electrodes usually last about a month or so. Did I disclose any? Yeah, these usually last about a month or so. Okay. I don't specifically work with any of these companies, so I'm a clinician. So my job is to basically figure out what I think is going to work best for you. I'm not gonna basically promote one company or the other. I'm gonna use what I think works the best, and you're gonna have the best results with. This is the Bioness. I like this one the best. There's what's called the Axiobionics walk aid. That's something that a lot of people probably have had in the past. I'm not the biggest fan of that one, just because it's so touchy. Like I said, you really have to get the sensors in the right spot. And you have to have the right pressure. So I'm not the biggest fan of the walk aids. There's a new one that's called a Psionic Neurosleeve. That one, you would actually contact the company, and they would reach out to you. So the Neurosleeve, I've looked into it a little bit. I'm not the biggest fan of it. One reason is it's big and bulky. It's an entire sleeve that goes around your entire leg, versus something like this, the walk aid or the Bioness is something smaller that wraps right around your calf. So I haven't seen anyone use the Neurosleeve. Feel free, reach out to them. Some of these companies, like the Bioness or the walk aid, you purchase the device. Okay. So their Bioness and walk aid, any of these FES things are considered experimental with Medicare. So most insurances don't cover them. Maybe if you had a VA or you had like workman's comp, they might cover it, but we've never been successful with any other type of like a commercial or Medicare or Medicaid replacement. None of them cover it, and they're expensive devices. So you really have to think to yourself, is this something that I'm willing to invest the time and money in? So around about the devices cost around $3,000 to about $6,000, more or less. So they're not cheap. They're expensive. Okay, so you really have to think, is this the right device for me? Versus if you get an AFO is typically covered by insurance. So sometimes I'll see patients and I'll be like, I like the AFO. It helps me. It's covered by insurance. I'm just going to start with that. But at least I know about FES devices, and that might be something I might transition to in the future. So yeah, feel free to reach out to NeuroSleeve. I'm not the biggest fan just because it wraps around and it's big and bulky. There's a new company that just got FDA approved called EvoWalk. I met with the CEO last month and talked to him for a little bit. It's really early in the design phase. They did get the FDA clearance, but it's early in the design phase. Just by looking at the design, I'm not the biggest fan of it, because you have to place an electrode outside of where the device sits on you, versus the walk-in and the Bioness, everything's kind of on one unit and you just put it on and you clip it and you're good to go. The EvoWalk looks like it's a little more patient. You have to be a little more savvy on where to place the electrode. Okay. So those are the 4 companies that I'm aware of. Like I said, the cost not covered by most insurances because Medicare deems it as experimental. Potentially, if you had workman's comp or VA, and that NeuroSleeve, I believe that one, when you contact the company, I believe that's like a monthly subscription versus a WalkAid or Bioness. Those are, you pay the full amount of the device, and then basically your yearly amount that you would pay would be for like the electrodes, which are pretty inexpensive. So my thoughts, FES is a great technology. Patients do really well with it. It's not for everyone. The orthoses always work, so I often do that combination of both the FES and an orthosis. And I kind of tell the patient, use your WalkAid or use your Bioness wherever most of the time. But if you're in a certain instance where that's not working for you, you can always fall back on the AFO. And then getting into physical therapy, again, with any of these devices is super important. I really wish that these FES companies would work on getting their devices approved by insurances. It'd be great for our patients to be able to use this technology. It's only going to continue to get better. So yeah. Any questions, comments?
Yeah, there are a few questions, and I'll let Katie and Kathy run those. But before we jump there, so Mike, if you can maybe share a case of a patient in which this technology actually did work, just to give us a context of how much of a benefit we should expect in best case scenario.
Yeah. So recently I had a patient that is bilateral foot drop. One side is worse than the other. And we talked about just doing the conventional carbon AFOs. And that's something that he started using, and he's walking great with it. But he said, I really want to use my own muscles, right? I want to try and maintain my strength because I have some swelling, and the FES device contracts my muscles, and that actually helps with some of that swelling. And I want to be able to do it. I want to be able to walk barefoot. I don't always want to have to put a shoe on. So we tried it out. We trialed it here in the office. We walked in the hallway, and basically each time he took a step, he had a great response. Not everyone has a good response. Sometimes it's hard to even get any sort of dorsiflexion response, or sometimes the response isn't what we want. Or sometimes these patients, they don't like the stimulation. It's almost like your leg falling asleep. I've had some patients that you turn it on and you slowly ramp up that stim, and all of a sudden they just shoot and they're like, nope, I don't like it. It's not for me. So it's a really small population of patients that it works well for. But this gentleman, yeah, he got the device. He started using it at home, and he's going to continue to use it. And I wanted to make sure that he was confident with one side. And then we're going to reassess the other side and see if he wants to go ahead and pursue one for the other side as well. With Bioness and WalkAid or any of the FES, it's always important to do follow-ups. Sometimes your gait might change. Sometimes there might be problems. Maybe you're not getting a good stim or something like that. There's always problem solving going on, and that's okay. That's what follow-ups are for.
So can patients test these devices before they commit to purchase it?
Yeah, yeah. So when I have patients come in to see me, I have a test unit where we'll actually try it on and see if they have a good response. If they have a good response, then we'll do some walking in the hallway, and see if it's something that they want to pursue. So when you come and see an orthotist, like such as myself, the way billing for us works, unfortunately, is we bill for the devices, not for our time. So you can come see us, we can try things out, see if it's going to work for you. And if it doesn't work, there's no cost or anything like that. It's only when you want to pursue a device, AFO or something like that, that we bill your insurance or there's some sort of cost. I see
So
any.
I was going to say there quite a few questions came through when you were going through the different companies. I don't know if you want to jump back to that slide.
Sure. Yeah.
And I don't know about you guys, but I got quite a few private messages. So if you want to check your chat as well and see if you got any private ones that the rest of us can't see, that might be good. But a few questions I got for you. First couple we're talking about, can you talk about which ones are covered by which insurance and that sort of thing, which I think you pretty much covered, but
That's easy. None of them, unless you have VA or workers' comp. Yeah.
yeah. Some other more specific questions. How durable are the Bioness L300 goes? What is the longevity? Start with that one.
Yeah, they're pretty durable. They should last you several years. The thing that you're gonna have to replace is the electrodes. And with the cloth electrode versus a gel electrode like the Walkaid has, you don't have to replace them as often. So you usually just come in, you get a 12-month supply. It's about $170 or something like that for the year. Um, everything has warranties. I believe the warranty of the actual unit is like 3 years, and maybe the cuff band is like 2 years. But when things break, I mean, if something's breaking because you're using it, that's great. That means you're being active and you're using it. That's great. But when things break, you can replace different parts of it. Usually, it's just like the Velcro on the cuff eventually just gets dirty, and you might just have to replace the cuff or the electrodes. Walkaid's kind of the same thing.
Another question about that Bioness was, what does the thigh component of it do? And do you always need to put them together, or is that patient dependent?
Yeah. So if you, let's say I have a patient who has a foot drop, but then they also have some knee instability and they buckle, you can have the thigh component up at the top, which is either stimming their hamstrings or their quad muscles. And basically the two talk to each other. So depending on what's going on while they're walking, it will go ahead and stim. So if the patient's about to take a step and they're about to buckle because they have weak quads, it could contract their quad muscles so that they're not going to buckle and fall. So usually the two work together. You can also, if it's just a proximal weakness going on, you can actually just do it, just the top piece as well. And Walkaid does not have that ability. I believe the NeuroSleeve does, and Evil Walk does as well.
There's another question. Are you familiar with the triple flex? And if so, what are your thoughts on this AFO?
What's it called?
The triple flex.
Triple flex?
Yeah.
I am not. Let me see if I can
Mike,
Google it.
while you search that, I have a question for you. So we just to test your multitasking skills. So we often use Botox injections for spasticity. And patients sometimes get injections in different muscles in the lower extremities just to help with spasticity. Will that interfere at all with the response to these neuromodulation devices?
Yeah, it certainly can. Yeah. Yeah. So that's why getting a good background information and continuing to see your patients as they're doing other sorts of medical like injections and stuff, because it can change the way the device is stimming them. So you might need to reduce the stim, or you might need to, maybe their gait has changed and you have to play with the timing of things. So anytime you are getting some sort of like spasticity treatment or something like that, it's always good to follow up with with whoever you did your Bioness or walk aid or whatever FES with. I just had someone just comment they've had their Bioness for 15 years. So yeah, they're technologies that can last a long time. They just have to get electrodes every year. Still trying to look up this triple flex.
Wow.
I don't know. I haven't used that. It looks like it's a device that's connected to your hip, that's connected to your knee, that's connected to your foot. I don't know. I've never seen it, but I've never seen any success with a device that has like a rubber band by your hip.
Okay. You're quite the multitasker. A few more questions came in. Oh boy. Coming in all over the place. Sorry, I lost which one I was going to ask you.
There's a good one here about are these options that you just went through with the AFOs and the FS, are those the only solutions that are available for foot drop, besides maybe like exercise and therapy, or is foot drop ultimately due to permanent damage?
I wouldn't call it necessarily permanent damage. I mean, it depends. I mean, MS is pretty fickle. I mean, there's some times where these patients are doing really well and they don't have issues and they're walking great, but then they have some periods in which they have a flare up and then they get this weakness and their mobility goes down and they need to wear a brace or FES during that time period. Yeah. What else was the question? Yeah, go ahead.
To add to that, I mean, MS is not the only cause for foot drop.
Right.
So sometimes foot drop is due to a peripheral neuropathy or a nerve problem. Sometimes it's just simply a transient compression on the nerve that compresses at the level of the knee. So people actually like to cross their legs. Sometimes they can induce some sort of transient foot drop. So when in doubt, it's good to discuss with your healthcare provider, neurologist. Sometimes we even do a referral to physical therapy to help us, tease out the source of the foot drop. And sometimes we have to do a nerve conduction study or a test to help us understand, are there any peripheral nerves involved?
Mike, there was another question. If you could possibly go back to the slide about the gait analysis, just so they could have another.
Uh-huh.
Okay. You are popular. I've not seen this many questions in the chat before. At one of these webinars, is there an FES device for hip or knee weakness specifically?
Yeah, you have to cross the knee or the hip. So it would be some of the devices that have the 2-channel, so that EvoWalk has a 2-channel. The Bioness has a 2-channel where there's basically a thigh component. So you can stim your quads or your hamstrings to get whatever effect you're looking for. So there are options. In terms of bracing, there are options to control that. AFOs, they have influence on what's going on at the knee, but because we're actually not crossing the joint, we're not completely controlling it. In order to really control the knee joint, you have to go with what's called a KFO. And that's a brace that comes all the way up your thigh. They're usually big and bulky and heavy, so patients usually don't like them. So I usually try and stay away from those for patients.
One's more of a longer one, but person says, I forgot the term, but many individuals with MS do a circular motion so the foot can catch. When you have been doing this for however many years, is getting an AFO worth it to change whatever is working?
Yeah, 100%. So there's 4 things that people do when they have a foot drop, right? the body, we're trying to walk in a way that we're not going to trip and fall. So what you described is called circumduction. So basically when you're taking a step, you're kicking your leg out to the side so that you can clear your foot. But by doing that, you're using your hip muscles, you're using your lower back muscles. So you might have, oftentimes people with foot drop have back pain because they're using muscles in a way that they're not supposed to really be used. Sometimes we'll do what's called high steppage gait, where you kind of lift up at your hip to clear your foot. Or sometimes we'll do what's called hip hiking, where you'll just kind of lift your hip up a little bit. And the last thing is what's called vaulting, where on your other foot, you're actually pushing up in the air so you're clearing the right foot. So all these are ways that our body try to move so that we're not going to trip and fall, but they're compensatory. So there's always something that's going on. Maybe it's overuse of your hip muscle. Maybe it's overuse of your back muscle. So if a brace or FES can get you back to a more normal gait mechanics, some of those things can hopefully improve.
Okay. He says thank you.
You're welcome.
Is there any risk of these stems causing issues if used for many years?
These what? Stems?
Like the I think stems.
Is there any, say that again?
Is there any risk of these stems causing issues if used for many years?
Oh, if used for many years. No, I haven't heard anything like that. The main things are if you have one of those contraindications, that's number one. Or sometimes you might have some sort of skin sensitivity because these are stems that are going through your skin. Sometimes people have skin breakdown. So if you were to have something like that, that would be a contraindication as well.
But I
Again,
want to use this opportunity to address one common scenario that we see in the clinic. If you purchase one of these in the past, or even an AFO, and you have it in the closet, you're not using it, that by itself should be a reason to see someone like Mike or whoever prescribed that before, because there's a reason why you're not using that. But that doesn't mean that there is nothing you can do about it. So always is good to check whether there's anything new that you have that perhaps is available for you, or if there's anything we can do to tweak with whatever you have to make sure that we can continue to address the food drug.
Exactly. Sometimes, if you're not using it, go see the orthotist that you saw that made it for you. Sometimes it's as easy as heating and flaring something, and then you're able to use it again. Sometimes it's because you're not wearing the proper shoes. Oftentimes people wear shoes that are too tight and small for their foot. So anytime you're using some sort of brace, people always complain, I can't get this brace into the shoe. Usually I recommend New Balance. They tend to be a little wider and deeper. That accommodates for the thickness of the plastic or the carbon or whatever. Skechers is also a good shoe as well. If you're wearing something that you have a hard time fitting your foot in as is, it's going to be hard to fit in with a brace as well. So you might be saying, okay, I want to go FES route because I want to wear whatever shoe I want to wear, and I don't want to have to change my shoe style for the brace. Maybe you'll use your FES when you go to church, you want to look nice, or go to a wedding or something like that. But then your normal every day, you're walking with your brace and you're walking with a nice pair of shoes, gym shoes.
I think there was one last question about shoes to wear with these devices, but I think you just kind of touched on that. And from my end, that was all of the questions I got privately. I don't know if you all had any other questions come in that I couldn't see.
That's it too. Just a comment still that the FES can't work with stretch pants.
Yeah. Any sort of device, you have to, there's always a plus and minus to it, right? So an AFO might limit the type of shoes that you can wear. An FES device might limit the pants maybe you're not gonna be able to put those skinny jeans on. Okay.
So,
or I've even seen patients put a zipper on the side of their pants.
very good. So I was going to ask you what just came in the chat box, Mike. If you can maybe let us know If patients wants to see you, what
Yeah.
locations are you, and what will be the process?
Yeah. So that's me. That's my email address. I only practice here down at Rush. So I am part of Hanger, which is a big O&P company. There's about 950 offices across the U.S. So you can reach out to your local Hanger office. Not every Hanger office has FES specialists. Every Hanger office probably has an orthotist that can surely, if you have any questions about AFOs or bracing, they can answer that. But not every Hanger office has FES specialists. So that's just something that I enjoy doing. I enjoy helping the MS patients with FES as well as the more basic AFOs. So if you have questions, feel free to shoot me an email. If you want to get scheduled to see, you can call that number there. Anytime you do go and you're getting something new, you have to get a prescription in order for a new device. So that's working with your doctor to get that prescription when you go in and see that orthotist.
Very good, Mike. And for those patients that get their care at Rush in downtown, Mike is right downstairs, 1 floor down from our office in professional billing office, suite 220. Is that correct?
220. Yep.
Oh, geez, I remember your suite number. It's incredible. Very good. On the 2nd floor. So, Mike, thank you very much. This was a great, very educational session. I'm sure our patients will benefit from what you discussed today. This is going to be available also for the recording for those patients who actually couldn't attend today. And for those who did, please stay tuned. Our May conversations on brain health is going to be equally interesting. We will have Monica De Giorgio. She is a neuropsychologist, and she is going to explain not only the potential cognitive consequences of multiple sclerosis, but most importantly, a recently developed neuroresilience clinic. So that's a clinic for MS patients who wants to improve their cognitive skills, perhaps patients that are worried about memory, attention, concentration, multitasking. What can I do to improve my skills? So it's a newly developed neuroresilience clinic that is part of our overarching brain health program that we are offering at Rush for our MS patients. Through that clinic, patients can have a very brief neuropsych testing. And most importantly, it's going to be associated with a clinic that will allow patients to know what can I do to improve my cognitive skills. So stay tuned. That's going to be next conversations on brain health in May. Anything else I forgot, Katie or Kathy?
I think you covered everything. That's pretty good.
And Kathy, you are running your 3-week brain health program in April, is that correct?
That is correct. And we're actually starting on a Wednesday. So that's going to be April 24th is the next one.
So this
Classes is getting full, but I still have a few spots available.
So if patients wants to register to the brain health program, what should they do?
Well, there's a registration link, but more importantly, I mean, for the sake of ease here, they can email me directly if need be, and I can forward on the registration link.
Very good. And your email is Catherine_Kiefer@rush.edu. And we can share that in the chat box. And for everyone else, thank you for your continued support, and we'll see you again in May.